Good morning, good afternoon, good noon. Happy Friday, everybody. Very excited for today today's case for many, many reasons. I'm a little sad because I don't know for sure if Prof. Rez is coming today. He was working a night shift and I have yet to hear from him, which means either he will heroically emerge amidst a Batman and Superman and Spider-Man poster in his background, or he will not, and he will be dreaming about said things at the same time. But either way, there's a lot to celebrate today because we have the return of one of our CP Solvers Academy members who is currently an intern, Umbish, who is presenting. But before Umbish and I chat and reintroduce her to you all, I want to give a big shout out to the folks who are making this happen. First is Khashar, who's scribing. Khashar, give us a sense of what's been new in this in your life this week.
Hi everyone. The new thing this
Yeah.
week is that tomorrow I'm gonna be starting my pediatrics infectious disease rotation
Oh,
for two
man.
weeks.
Nice.
It's gonna be fun.
I bet. I bet that's going to be very, very interesting. By the way, I don't know if you know it, but you made me laugh so hard in the CP Solvers Academy WhatsApp group. All these folks were chatting about their fancy schmancy keyboards, which Noah is using as we speak. Yes. And Kasha, I was like, what are you guys talking about? I still write paper notes and I lost it. So thank you for that free giggle. In the teaching point slot, a continent away, not quite a continent, half a continent away, is Ethan. Ethan, what's new with you?
Hi everyone. So I'm doing my military training, which is compulsory in Taiwan, and
Yeah.
serving a government office. I feel like it's like paying a debt owed to the country. So,
Yeah.
but I'm more free after finishing the basic military training, and so I can join more sessions. And really excited for Amber's case today. Yeah.
I know we're hearing from Iran, we're hearing from Taiwan, and here I am babbling to you from San Francisco. I will say though, Ethan, I too stumbled into this haircut not by volition, but by circumstance. And the circumstances were that I was trying to cut my hair and I accidentally buzzed it off. And now I have come to stick with it forever. So I'm really curious what you're gonna evolve to after your haircut is no longer compulsory. We'll see what it eventually is.
We'll see. We'll
Do
see.
you like it or not really?
Not really.
That's awesome. That's so funny. I also see a couple of people who I've worked with here in real life. I see Connie is joining us for the first time. Hi, Connie. And I see Nick is here too, two of my former acting interns who are absolutely awesome. Welcome. Um, Ambish, tell us what's new, please. Or maybe you might have to tell people a little bit about yourself since it's been a minute, but tell us what's new.
Thank you, Ravi, for having me at this special RLR because I know you're not feeling well. So I feel especially honored that Ravi was able to make it to the RLR today. And I'm hoping Reza also makes it. As for me, I think a lot of you already know me. I'm Umbish Dino. I'm one of the Academy members. And I'm an intern currently at the University of Wisconsin in Madison. And I'm 5 months into my residency, and I'm really excited to be going home to my son and husband this weekend. And also really excited that I'm presenting a case after it's been ages actually. So it feels like home already.
We're so excited to have you back. And I remember the first time we connected where what you're currently doing now seemed like a very far-fetched dream. And here you are absolutely cruising in the middle of your intern year. And I think it's so perfect that you're presenting on this platform on the day you get to go back and be reunited with your family and the tremendous sacrifices you've made being away from your son and your husband for so long. So very excited. And I think that as you mentioned that excitement, we get the beaming, soon to be beautiful smile. There you go, of Prof. Rez. Prof. Rez, Umbish is back. She's presenting a case for the first time since her intern year on the day that she's going back to be with her family after not seeing them for many months. So that's catching you up. Welcome. How are you?
Wow, what a treat. Sorry for my delay. I was asleep, but just woke up and am ready to rock. How are you feeling?
I'm doing well. I told Amish I wouldn't be here if it weren't for her, and she told me the same. The same. Um, But Prof Raz, we were speculating on your dreams and what they might contain since I mentioned to folks that you might be sleeping, but very, very excited that you emerged in time. Do you feel awake enough to tackle the first aliquot, or do you want a little bit of time to sip some coffee or something of the like?
No, I'm ready. Let's do
All
it.
right, okay, let's rock and roll. Ambish, the mic is yours, my friend.
All right, let's get started. So this is the story of a 44-year-old gentleman with no significant past medical history who was presenting to us with a 2-month history of nausea, vomiting, and weight loss.
Yeah, Amish, this is a really exciting start to the case. I think in general, many times people might have some nausea, and nausea in itself is quite non-specific, meaning there can be so many causes of nausea. And oftentimes, if someone is presenting with nausea, we seek another chief concern that might have more specificity for problem solving. In this case, I think when you have nausea and vomiting, it's really pointing to a likely gastrointestinal pathology, at least with this set of information. The weight loss in our mind is probably a consequence of the nausea and vomiting. So, right now, I think what gets prioritized is something within the gastrointestinal tract. And then using the tempo, which is 2 months, you can say that this process is subacute bordering on chronic. Because most causes of nausea and vomiting is a gastroenteritis or some kind of food poisoning, but those are usually short-lived, meaning you may have some vomiting, some nausea for a couple of days, and then it resolves. So we have to go beyond the common cause of nausea and vomiting and broaden to more of a subacute to chronic process. Honestly, I'm just going to leave it at that because we still don't have a pivot point. We don't have a specific problem. All we know is that this process is not acute, it's subacute, and probably pointing to the GI tract, and that we're getting a lot of hearts from Robbie. So I think that's a good stopping point, Amvish, and I'm going to give the mic back to you.
All right, so for the HPI, this patient was actually in his usual state of health until 2 months ago when he suddenly began experiencing persistent nausea and vomiting. And this was accompanied by the onset of abdominal distension, prompting his first admission to the outside hospital. And then during that stay, he was found to have ascites of unknown etiology. And following discharge, his symptoms kept worsening. He stopped eating and he couldn't eat. He could only tolerate liquids. And then he continued to experience severe nausea, vomiting that led to his current hospitalization. And I'll let you guys ask me questions, or I can give you the pertinent positives, whatever works.
Yeah, no, I think Bish, I can reflect on starting. I think Prof Raz's suspicion that we'll find a pivot point, I think, has panned out because you've translated the nausea and vomiting and found a very plausible culprit for that symptom complex, which is there's a significant amount of fluid in the belly in the form of ascites. And I think now you can translate this problem to a 44-year-old man who has ascites and weight loss. And I think that's essentially replacing the nausea and vomiting with a very plausible explanation for the nausea and vomiting. And so we now start to say, well, what do we need to know about the ascites to understand it better? And as is true for any fluid that gets into a serosal space, you want to understand the basic mechanism of how it arrived there. And there are two fundamental mechanisms of how the fluid can arrive there. The first is that it can arrive there through leakage of vessels that are intact. And the vessels leak the fluid even though they're intact because they're under high pressure. And that results in a transitive fluid that is devoid of many things and empty of protein, empty of albumin, empty of LDH because the vessel wall is intact. The other hypothesis is the fluid got there because the vessels that should have been holding it in became leaky. And that fluid, called an exudate, is full of LDH, full of protein, and full of albumin. And the most common culprit for leaky vessels are inflammatory diseases like infections, cancers, autoimmune diseases. But there are exceptions to these rules. So I think that um, the key question that we're going to try to answer is, what is the nature of this fluid? Is it a transudate or an exudate? And analysis of that fluid at the outside hospital will probably be illuminating, but all tests have to have a pre and a post test and a pre-test probability to analyze their significance. And one helpful thing is almost all transudative effusions are accompanied by weight gain. There is no reason for the patient to lose weight when they have high pressure causing fluid to leak out. The overlap of developing an effusion in the context of weight loss is very suggestive of underlying inflammation of any variety that beneath the surface triggers leak of a fluid and as the underlying cause and driver of inflammation-inducing weight loss. And in fact, you can estimate this patient's total solid weight loss to be significantly more than just his actual measured weight loss, because the fluid that he has accumulated artificially normalizes his weight. So I think what would be most telling for this patient is to reinforce the hypothesis that this is in fact an exudative ascites, and to do so and to reflect on that, maybe I can just ask Professor to sort of share with us how he goes about that space. But I think that's the crux of the case now, is to understand the nature of this fluid, with the pre-test probability being that of an exudative nature.
Robbie, I think it's such a great pearl of weight loss and volume overload pointing to an inflammatory state. And I first learned that from you when there was a patient with heart failure and weight loss. And I think it's such a great clue to, like, the nature of this fluid. And I think that the simplest way to approach an exudative ascites, first of all, what we're going to get is the sag. You see, anytime anyone has new ascites, there's two very important questions to ask. One, is there evidence of infection, and are you dealing with bacterial peritonitis? And then two, what's the nature of that fluid? Is it transudative or is it exudative? And the way you answer that is by looking at the white blood cell count and the neutrophil, the amount of neutrophilia in it. And then two, you look at the serum ascites albumin gradient. And we already know, like, this is what's so cool about clinical reasoning. Like, there's no chance this is spontaneous bacterial peritonitis, meaning there's a possibility that someone has an infection of the acidic fluid and is presenting now, but it can't explain, like, cirrhosis is not going to explain the ascites here, right? Because SBP is an acute process. We've already established the nature of the clinical syndrome as subacute. So it can't be cirrhosis causing a transudative fluid and then having an SBP and now the patient's presenting. So we're going to expect the SAG to be less than 1.1, and that is suggestive of exudative. And then you just have to use the IMADE mnemonic and say, is it infection? Is it malignancy? Or is it autoimmune? And most often, when you're dealing with acute ascites, you when you're actually with subacute ascites and worldwide, in a common infectious etiology would be TB metastasizing to the peritoneum and causing leakage of this fluid. But it's not only TB. Fungal infections can also cause a leaky ascites, a leaky fluid and exudative ascites. Cancer in the form of metastases to the peritoneum, in the form of lymphoma, and a prototypical autoimmune example of an exudative ascites is lupus. So I think that if this person was a female, then you would think about GU malignancy as a common cause of exudative ascites. But that's really my approach to it, Robbie, is that I expect the SAG to be less than 1.1. If it's infectious, I expect it to be more of an atypical infection, just given the tempo. And then of cancers, I expect either mets of the peritoneum or some kind of GU malignancy. And autoimmune, I think the best example is lupus. So there's other causes of serositis that can lead to exudative fluid. So I'm very interested in more information from Ambish, so we can make more progress onto the nature of the ascites?
All right. I am loving the discussion so far. So I'll give you guys a little bit about the review of systems. So for the nausea, vomiting, it was persistent and it kept worsening to the point that he couldn't eat. And even he could tolerate some fluids, but even drinking fluids at the point when he came to us was intolerable. And then in terms of the weight loss, he had significant unintentional weight loss of approximately 40 pounds over the past 2 months. And he wasn't eating, so he was severely fatigued. This was accompanied by lots of weakness, increasing lethargy. He stopped going to work. And then overall, his energy levels were significantly decreased. As for the abdominal distension, I know that there's history of abdominal ascites, but when he presented to us, he actually didn't look distended. And I'll go over the physical exam later. As per in terms of the review of systems, everything else was actually negative. Do you want me to get into the social history, family history, or should we hold off on that?
That sounds great. Yeah, go for it. Go for it.
Okay, all right. All right. So in terms of everything else, no fever, no GI disturbances, no illnesses, none of that. He did report moderate drinking before long time ago. So before he started, feeling sick, many like months ago, he was drinking, and I asked him if he used to binge, and he said sometimes he would binge. And there was also some history of marijuana use and some smoking, like very distant history. But then he was saying, ever since I started feeling this way, I stopped smoking, drinking, so no drugs. In terms of his work history, he had been working in roofing for about 20 plus years. All his life, he was working in the roofing business. And then in terms of his medications, since his last admission, he had been put on furosemide 20 mg once daily. He was on ondansetron 4 mg, sorry, twice daily. And he was also on spironolactone 50 mg twice daily. And then no other meds that I know of. In terms of his family history, he had an uncle with alcoholic cirrhosis and no other GI or any other illnesses in the family. Other than that, no travel history, no. And then in terms of the outside workup, I can go over that shortly, but that's it for past history.
Maybe I can be brief here because I think we still need the data to be confident in what we're trying to solve. But what I'll say is that there's only one emerging cause of performing a therapeutic paracentesis, only one, meaning oftentimes a paracentesis is never needed in an emergent basis. It might be needed that day, but there's only one emergent cause, and that's when you have abdominal compartment syndrome. And so if anyone has ascites and they're presenting with what seems to be obstructive symptoms of nausea and vomiting, you really want to entertain that possibility that that fluid accumulated rapidly and is now causing abdominal compartment syndrome. And this can be very bad for the kidneys and perfusion of organs, and you have to do an immediate paracentesis. I've never seen a case, so it's important to look up like exactly how that looks. And you can measure the pressure in the abdominal compartment through a Foley catheter as a surrogate. So I think that's an important teaching point. As far as cirrhosis and drinking, yeah, drinking can lead to cirrhosis. If someone has cirrhosis, they can lose weight. We know that when you have chronic injury of organs like the liver, like the heart, like the lung, that can lead to weight loss over time. But this just seems a little too rapid for that. So it's hard for me to dismiss and say, hey, no, this is not an inflammatory cause of ascites because he's drinking and has cirrhosis and has lost weight because of his cirrhosis. We still have to look at the nature of that acidic fluid. But I just want to say that's a plausible theory that someone has been drinking so much, they develop cirrhosis. They may even have ALK-HEP. They stop drinking and they lose weight despite gaining fluid in the form of ascites. And the marijuana, yeah, maybe you're thinking, oh, can this be cannabis hyperemesis syndrome and he's just smoking a lot? It's just not enough to explain everything. Like we're not just trying to explain nausea and vomiting. There's much more here. There's weight loss, there's ascites, there's abdominal distension. So all that is to say, usually when we give furosemide and spironolactone, that's for portal hypertension. So I'm going to be really curious to what the SAG is and whether they really thought this was cirrhosis and portal hypertension, and that's why he was initiated on those. Because furosemide and spironolactone, while effective against a transudative cause of ascites from an increase in pressure within the hepatic parenchyma, it's not effective for exudative. You got to treat the underlying inflammatory process. I'll see if Robbie has anything to add before we pass the mic back to you, Ambish, to give us more data for us to try to really figure out what we're trying to solve here. Right, Robbie? You want to solve the problem.
All I have to say, Prof, is whatever angle and position you were sleeping at before this VMR was very effective. So try to replicate
I
that.
was in Trendelenburg to get blood to my head, so I can
There
be
you
ready for
go.
you.
It's working. It's working very effectively. Alrighty, Amish, mic to you.
I 100% agree with Ravi. I feel like whatever was going on, it's totally working for you. All right. So for his vitals, his blood pressure was pretty normal the whole time. It was 120/84 on most days. And then heart rate wise, he was tachycardic at 104. And because he had a long hospital course, so this is like a mean, vital summary for him. And then for his respiratory rate, it was 16 breaths per minute. His temperature, he had like a fever here and there, but overall he was pretty afebrile. Oxygen saturation was 99% on room air. BMI was 18. And for his physical exam, he was a very thin appearing, frail man with severe temporal wasting, marked muscle wasting in both upper and lower extremities. He had a very cachectic appearance. We were very, very concerned for the way he looked. So we, the whole time he was on an NG tube, and we very quickly transitioned him to total parenteral nutrition because he just wasn't eating. And then for his physical exam, his again temporal wasting, no JV distension, no lymphadenopathy. Cardiovascular exam was completely unremarkable. Respiratory exam, lungs were clear to auscultation bilaterally, no wheezes, rales, or rhonchi. Abdomen, even though he had that history of ascites and distension, every time I would go in and look for ascites or distension, I couldn't really appreciate anything. His abdomen was very, very stiff to touch, and then very rigid, no rebound tenderness, bowel sounds were active, no distension, and then other than that, extremities wise, he would have this unilateral swelling that would keep coming and going, and other than that, physical exam was unremarkable.
Very, very interesting, Ambish. I think that's very, it's very important to be careful now, because I think that your inability to find ascites either means there was none or there was a very small amount. So I think we're at risk of overemphasizing the presence of ascites in this case. And I think I would probably reformulate it to subacute wasting syndrome, as evidenced by the tremendous amount of weight loss. And I think that now we really, really emphasize what the weight loss does for us. It tells us that this patient has a very serious process going on that is causing them to lose muscle mass. And now we're on the hunt for where that process is geographically located within his body. And so I think the thing that I would want to know most importantly is whether to understand his localizing sign, and his localizing sign seems to be in his abdomen, given your physical exam findings of pretty significant tenderness. I think there are some things that we should perform and everybody with weight loss, and that's an HIV test. But short of that, I think now the calculus is all about, really all about finding the asymmetry and finding the consumptive process that, based on his exam, is likely hidden in his abdomen. I think the lack of jaundice and the relatively normal blood pressure are pretty strong arguments, let alone the absence of ascites, against the presence of portal hypertension. So what would I do now? I would be very interested in actually scrutinizing the outside hospital records to see if they were able to actually remove fluid. What did that fluid show? And I would be most interested in understanding why his abdomen is diffusely stiff. And there's only really two things in the abdomen that are present diffusely. And that's the lumen of the GI tract, present all the way, everywhere. And the other thing is the peritoneum. So whenever you're dealing with diffuse abdominal disease, the calculus, is this a luminal GI disease going from small to large bowel, or is this a peritoneal disease? And the presence of the stiffness and the rigidity has me worried that, as Prof. has mentioned, this might actually be a subacute peritonitis. Now, that phrase is probably mildly familiar to you all, given the emphasis of acute peritonitis in the context of gastrointestinal perforation. But there are subacute diseases that affect the peritoneum. So my leading hunch right now is that this patient might have a subacute peritonitis with intermittent ascites as a result of that peritonitis. And that operating hypothesis would want me to image his peritoneum fairly quickly. So the major, I think, helpful action step will be in this patient, which is unlike most patients with ascites we take care of where we tap their ascites and get an ultrasound. I think the most productive path forward for this patient will likely be getting a CT scan with contrast, owing to the hypothesis that the disease either originates or lives in the peritoneum for this patient. So that would be what I would interpret from this exam. I'm really curious what Prof. Rez has to sprinkle on.
Robbie, can I share the funny story I wanted to tell the folks?
For
So
sure.
yesterday or 2 days ago, no, yesterday, we had a talk at 5 in the morning, our time, where we were discussing two clinical unknowns. And the person who introduced us is a dear friend. We love this guy, Dave. And he started with Robbie and he said, you know, guys, Robbie is very rare. He's the clinician, he's an educator, he's a scholar. In academic medicine, we view this as a triple threat. And then he said, Reza has a great smile. Okay, let's get started with the case.
Prof. Rez,
Dude, that was so
that
funny.
seemed to wake you up at 5 a.m. in the morning, that comment.
Dude, that was, and then Robbie, when his first words out of his mouth was like, well, guess what, guys? I'm the triple threat, but Prop Rez didn't get a single threat. Dude, I was thinking about that and just laughing so hard throughout the day yesterday. It made my day.
I don't think anybody can attach the word threat to you, Prof. Rez. I think there will be a lot of difficulty with that. I don't know how to transition back to Ambish in my in my myalgias now. But Ambish, please save us. What do you have next?
All right, so I'll start with the basic workup. In terms of his chemistries, sodium was fluctuating between 127 to 137 throughout the hospital course. He had hypokalemia, ranges between 22.8 to 4. He had hyperchloremia, 74 to 101. Bicarb was elevated at 42. BUN was elevated at 32. Creatinine was stable the whole time. Glucose was pretty stable. LFTs, ALT, and AST were normal, and alkaline phosphatase had been elevated the whole time in the 200s. It actually kept going up, but not too much. It was in the 230s range the whole time. Total bilirubin was normal at 0.9. Albumin was low the whole time at around 2 to 3. Total protein was 6.3. For his hematologic profile, his hemoglobin was between 11.9 to 12.9. Hematocrit was 36%. Platelet counts 217,000. WBC counts were normal. And then for his workup that was done at the outside hospital, it was very, very extensive. I won't get into it, but I can just give you some information on the hepatitis panel being negative. HIV was negative. TB, all of the TB workup was negative there, and we repeated it, so it was negative. And then they did all of those ceruloplasmin and all of those things, and ceruloplasmin was mildly elevated at 37. Ferritin was elevated at 419. Iron studies revealed low iron at 38, low iron saturation at 14%. And then as for the aseptic fluid analysis at the outside hospital, the protein was more than 2.5. And then I'll just give you the SAG ratio. It was 1.2. And then the cytology that they did was negative for any malignancy, and this was a single sample. And again, as Rabih and Reza have both been highlighting, it was actually so small, the aseptic fluid, that they couldn't really extract much. And even when we saw him, we tried repeating, but we couldn't really get any sampling. when we would look into his abdomen, we would see a lot of fluid, a lot of like tissue, inflammation of the tissues, but we couldn't get more fluid to tap. And then I will go into the imaging studies. So ultrasound initially done was pretty unremarkable. We did get a CT abdomen and pelvis with IV contrast, and I'll show you the image for that, and then I'll give you the interpretation. I guess it's a bit blurry, but I hope you guys can appreciate the image. Right. Can you all see the image?
Yeah, it's very, very interesting, Ambesh. I'm curious, did the patient get oral contrast by chance, or do you know? I'm trying to see if what the lighting up there is at the
It was
lumen.
IV. Sorry, it was IV contrast.
Interesting. Yeah, I think this is a perplexing image for me, honestly. I would have to scroll up and down. I'm having a hard time figuring out what what is taking up space in the patient's abdominal, like the central area. I mean, probabilistically speaking, it's bowel, but it seems to be very different than the bowel that's located in the patient's right lower area. So I don't appreciate much fluid, honestly, but I'm really curious what you're thinking, Prof.
I'm thinking, what is the report going to tell us? Ambish, what was the interpretation of the CT scan?
All right, I'll give you guys the findings. So it showed a lot of diffuse small bowel and stomach wall thickening with bowel wall edema. And even though, like I said, we were able to see ascites and fluid, but we weren't able to tap it. So there's basically wall thickening, dilatation. And I don't know if you can see my cursor, but in a normal person, you actually cannot appreciate these boundaries here. So this kind of reflects the inflammation of the peritoneum and the bowel in general. Like there was a lot of inflammation going on. So, we were able to appreciate just lots of distension. And as Reza had already mentioned, compartmentalization was also visible here. And that's where we were stuck up until this point. And I'll stop sharing the image. If you guys want to discuss, I'll stop, but I can then go into other things that we did for this
No,
patient.
I think we can start discussing. You gave us a lot of good data here, and maybe Robbie, we can go back and forth. I think of all the labs, it didn't surprise me. The only, like, I'll tell you what caught my attention. One was the elevated alk phos. Like alk phos, when it's elevated, usually originates of one of two areas in most comers, the bone or the liver. And because this whole case has been centered on ascites GI pathology, it's good to anchor on the liver being the source of the alk phos. But you definitely want to confirm this with the GGT. If the GGT is elevated, then we know we're dealing with a liver origin of alkaline phosphatase elevation. And that would be a very powerful clue in this case, because when you have isolated alk phos elevation without AST and ALT, it really prioritizes an infiltration within that liver. Like that's going to be the most likely culprit if that GGT is elevated. But once you say infiltration in the liver and then you look at that CT scan, the bowel wall edema can be translated into inflammation of the bowel wall. And we're back to what Robbie said in the first aliquot, that he's worried about an inflammatory process. And when you think about that bowel wall edema, in addition to common causes that we see from gastroenteritis to inflammatory bowel disease, you also have to consider infiltration within the bowel wall. So all of a sudden, I'm starting to wonder, is something infiltrating the liver and the bowel wall? And the way that infiltration, like what are some causes of infiltration? Well, it includes stuff like malignancies. For example, a lymphoma can infiltrate the liver, it can infiltrate the bowel wall. Usually you'll have lymphadenopathy, but that would prompt me to say, hey, Rez, maybe you want to send an LDH. Amyloid can definitely infiltrate various areas, but usually it'll leave a fingerprint on the kidney or the heart as well. And we're more dealing with like the liver and the GI tract. And then there's IgG4 related disease that can cause infiltration, and histiocytic disease, Langerhans and non-Langerhans. But practically speaking, when I see infiltration like this, I'm like, is there a cancer specifically in the form of lymphoma that or a GI malignancy that's infiltrating the liver and the GI tract? Is there some kind of infection in the form of granulomatous disease, like tuberculosis, fungal disease, that has now invaded the liver and the GI tract? Or is it a molecule like IgG4 related disease? And whenever you have the GI tract, you also have to think about eosinophils, but I don't think the liver is, maybe it probably could be a part of that syndrome, but eosinophilic infiltration. And then the other thing that caught my attention was the fact that the platelets are normal and the albumin is low. And there seems to be a slight protein gap. And that low albumin is probably just from inflammation. I would probably send an ESR and CRP just to confirm that hypothesis. But because Ambish said seemed to be a lot of thickening of the skin as well, you just want to make sure there isn't nephrotic syndrome. So a low yield test would be urinalysis and a protein to creatinine ratio to make sure that you exclude that. But the other laboratory, like the hypo-K, they're on furosemide, the sodium is going to fluctuate. So for me, Robbie, the high alk phos, normal AST, ALT, bilirubin, likely liver sores, likely infiltration. The bowel wall edema, less likely inflammatory bowel disease, more likely infiltration. And there I'm thinking cancer, lymphoma, GI malignancy, or infection in the form of a granulomatous infection, tuberculosis or fungal. But yeah, I would love to hear from you, like where your thoughts went with this.
Yeah, Prof. Rez, I'm intrigued. I don't think I've ever seen anything like this before, and I think it just highlights the importance of being very, very meticulous about what you call the problem. And I think that initially this was a problem of ascites and inflammatory ascites, but I think it's been radically transformed to a problem affecting the lumen, as you articulated. And I think that I don't have any wisdom to offer apart from to share the intrigue and describe how unique the syndrome is. Because what we're essentially saying is from stomach to the end of the small bowel, this patient has disease all the way from the stomach to the small bowel, but the disease has not taken up shop anywhere else and has refused to spread beyond those boundaries. I mean, think about it. It is a selective, devastating, extensive, but restricted disease to the GI tract. And I find that very, very intriguing. And I find that very, very hard to reconcile with anything that I know. Because everything that I know that infiltrates the GI tract, with the exception of eosinophilic gastroenteritis, goes to other places. IgG4 disease, amyloid, lymphoma. And sure, early on, infiltration in the GI tract might be too early for it to have declared itself in other ways. But the amount of devastation it is rendering on this patient's intestines with relative sparing of everything else, of course, with the caveat that the alk phos is high, but the proportion, if the alk phos were 500, 600, I think that would make sense. But here, we know the alk phos also comes from the GI tract a little bit. So I don't know. I'm very, very intrigued by that formulation, and I'm really curious to continue to try to update this problem as a devastating intestinal disease or a devastating intestinal disease with yet to be recognized extra intestinal clues. And I think that this is where looking at the EKG to see if there are low voltages that you might have missed, or looking at the urinalysis to see if there's proteinuria to suggest renal involvement that you might have missed. So I'm in that space now, Prof, as like you, where I've really updated my problem representation. Say this is a devastating intestinal disease. And I'm really curious if there are any other extra intestinal manifestations to make it an easier problem to solve. But anytime, I think my biggest piece of advice is anytime that you're stumbling upon an incredibly unusual problem is to ask yourself, do you have that problem right? And so I'm asking myself, is there any way that I'm representing this problem as a diffuse intestinal disease incorrectly. And I'm wondering about that because of the compartmentalization of the bowel, that the bowel seems to be trapped and encased in a cocoon-like manner, to wonder if actually the origin of the disease is right next to the bowel in the peritoneum. And there's something about the peritoneal inflammation that is containing the bowel and trapping it. And that's why the disease looks like it's an extensive bowel disease. But I'm not sure why an extensive bowel disease will choke off the bowel and contain it in the manner that it seems to be in the image that Ambe showed, and the word that she used, which is compartmentalization of the bowel. So to summarize, I'm very, very intrigued by how restricted this disease appears to be in the stomach and the small intestines. I'm wondering if that's true restriction or false restriction, but I'm also wondering, given how unusual that space is for me, it might represent a knowledge deficiency, but I'm very careful to make sure I'm not falsely jumping to the luminal GI tract and curious if the peritoneum is the site of disease and somehow fooling us into misleading the radiologist to think the disease is in the GI tract. So I just said a whole bunch of things that may sound wise, but actually have no idea how to move this forward, except maybe to have a reanalysis and a conversation with the radiologist about where they think the disease might be, and just to look very closely for extraintestinal clues.
Let me ask you, Robbie, if it is the peritoneum, how does it change your DDX from like infiltrative GI?
I don't think it does too much, Prof. Rez, except I think it becomes so much more plausible for the peritoneum to be a site of metastatic disease than the entire GI lumen to be a site of. So in other words, the peritoneum is a much more plausible site for diseases to go to rather than the diffuse GI tract, which is a very rare site of disease to be restricted to. So, I think we've all seen cases of isolated TB peritonitis. You discussed a really cool case of disseminated cocci to the peritoneum on human DX, but none of those, as far as I know, have a predilection to diffusely affect the bowel as it does. So I think it just gains a little bit of plausibility to be like, oh, those things that you were suspecting of early on are much more likely for a diffuse peritoneal disease. Just don't know how they would diffusely affect the bowel without being somewhere else, I'm intrigued, very, very intrigued, and I'm very glad you're presenting this case today. What do you have next for us?
All right, so before I go into the imaging data further and the biopsies, I just wanted to share that in the meantime, we were very frustrated with what was going on. And every time we would, take the next step, we would get deviated by, a new finding, and we would be like, oh, just like you guys are right now. So I was just sitting there and I spoke to my attending and I was like, I want to do some tumor markers. And I know they're pretty non-specific, but I just want to do them because we were all thinking along the lines of a GI malignancy. So I went ahead and got CA 125 done for him, which was elevated at 468. CA 199 was elevated at 1005. CEA was also elevated at 7.7, and AFP was normal. So now I was just trying to narrow down the diagnosis and see what the next steps were. But in the meantime, we had consulted with GI and we took him for an endoscopic ultrasound. The endoscopic ultrasound findings were basically esophagitis, a 6-centimeter hiatal hernia, and again, lots of congestion and erythematous gastric mucosa, suggestive of chronic gastritis. And every time I would try to go in, they actually tried twice, and it was very frustrating because there was so much edema and resistance that they wouldn't really get down into the stomach. And then they did notice some diffuse abnormal echo texture of the left lobe of the liver. So now this is where we got distracted and we were like, okay, it looks like something's wrong with the liver. Alk phos is elevated. I know Reza talked about gamma GT. I think I'm pretty sure it was elevated as well. And then we did get a liver biopsy later. I'll get into that. But before that, I wanted to talk about EGD. So EGD, very similar findings. We took biopsies. So we did a stomach biopsy. It did show findings that were basically inflammatory, gastropathy. And then other than that, no H. pylori, no evidence of any malignancy, even though we were very, very suspicious. And then the small intestinal biopsies were just showing, again, gastric heterotopia. Liver biopsy was also unremarkable, so no malignancy identified so far with those background of elevated tumor markers. And I will stop here. I did not give you guys in-depth reading of the biopsies and ultrasounds, but in terms of the rest of the workup, we got an MRI of the head done just to see if there was any intracranial malignancy, because we were now thinking of any form of metastasis, so it was unremarkable. Echo was pretty normal. I saw Alec talking about pericarditis, so no evidence of any pericarditis. And this is where I'll pause and reveal the final studies that we did to get to the diagnosis.
I think you're getting Prof. Rez, both and I staring at each other, because at least I am utterly clueless. Yeah, I think I find it very, very intriguing that when you biopsy it from the side of the lumen, you don't get clarity. And that really means to me one of two things, which is either the disease is much deeper than you've chosen to biopsy, in which case you need to biopsy from the other side, or the disease is around the lumen, not in the lumen, i.e. in the peritoneum. And so I'm very, very intrigued by that hypothesis. Again, this is not a space that I'm familiar with. And so what I would probably do is wonder if better imaging in the form of MRI, MR enterography might be elucidating. Or, in the quote unquote olden days, this patient would probably get a diagnostic exploratory laparotomy and do biopsies of the bowel and the peritoneum. It is very interesting that you seem to have not found any prominent extra-intestinal clues. And so I think the question is this a disease deep in the GI tract, like eosinophilic gastroenteritis? Some versions can be subserosal, very deep in the wall. Or is this a disease of the peritoneum? And in fact, if it is a disease of the peritoneum, there's only really one scary condition to think about, which is a condition that Prof. Rez told me when he presented a case of primary peritoneal mesothelioma, which was a very emotional and powerful case for many reasons, which is a thought that actually you planted, Ambish, that wasn't worth mentioning until now, given his roofing history and possible exposure to asbestosis in that context. There are other diseases that are restricted to the peritoneum that are idiopathic. One of them is called sclerosing encapsulating peritonitis, which is usually a complication of patients who get long-standing peritoneal dialysis, but can happen in a small fraction of patients idiopathically. So I only mentioned these two fleeting conditions that I'm not nearly an expert in, but I know that they exist as a way of plausibility of understanding where this disease is. And for me, this disease seems to live either deep in the GI lumen or on the other side of the GI lumen in the peritoneum. You have really boxed it into that area. So I think what you really need is either higher quality imaging or the expertise of a general surgeon to help you understand what this disease is. That's where I'm at, Prof. Rez. I'm curious where you are.
I'm so impressed by your memory, both the human DX case and the mesothelioma case. I think I'm right there with you, my friend. I think an MRI is probably going to be our best next test, because that'll just give us much more clarity to the soft tissues in that area. And if that confirms our hypothesis of a peritoneal disease, then the next step is a peritoneal biopsy. And I actually totally missed the roofing history, but often cases of mesothelioma, the history is not obtained until the diagnosis is obtained, because there's a distance between exposure and manifestation of the disease. So like there was 20, 30 years ago, the person worked in a shipyard or had the asbestos exposure. So in this particular case, and it often is like this, like, you think it's cancer, and the tumor markers are really non-specific. They can be elevated in non-GI or GU malignancies. So I really do think that ultimately, too, with mesothelioma, the pathologist will get the biopsy and it'll be a pathologic diagnosis. So bottom line, I think an MRI, and then from there, probably a biopsy. And if it is mesothelioma, that's bad news, because that prognosis is quite poor once that disease manifests. It's much more worse when it's like liver, like abdomen and pulmonary. But even with just local abdomen, this seems like it's metastasized all over the belly, and all of a sudden you do surgery, you instill chemo into the peritoneum, etc. Not to get ahead of ourselves, but usually the case of mesothelioma is one where you just can't find the common cancers and it doesn't show up in the cytology. And then all of a sudden you do that biopsy and you clinch the DX. So very curious. So what the next steps were, Ambush? I think MRI is a great thought, and then a biopsy is a very good thought.
Okay, so I'm just in awe right now. I don't have words. I'm so impressed by both of you, and I love how you guys are so down to earth. And like, we're not experts, but you are experts, and you say all the right things.
All the
Okay.
Trendelenburg, Ambush, all the Trendelenburg this way.
All right. So in terms of where we were at, all of the things that you guys mentioned, we had those options, but we couldn't get a laparotomy done because he was so weak. So everybody was kind of scared to touch this patient. Any kind of invasive procedure, they were avoiding it. They even deferred a colonoscopy because they were like, his intestines and his whole, like, he looks so fragile that we are scared that in trying to diagnose him, we'll actually, cause a lot of harm. So what ended up happening was we discussed with oncology, because GI had reached a blind end, and they were like, we don't know what to do moving forwards. We know there's a malignancy, but we cannot do a laparotomy for this patient. So we spoke to oncology, and then we ended up deciding to take him for a PET CT. And I'm just going to share an image, and I want to know what you guys think about this. So this was our first point of understanding what was going on with this patient. Can you all see the image?
Yeah, maybe I'll take a crack at this because Robbie talked about the other image. But a PET scan is basically you're tagging a tracer with glucose, and areas that have high metabolic activity will light up. So like an easy way to look at that is look at the brain. It's lighting up because the brain is highly active. And that's why a PET CT is not the best test to look for intracranial pathology. And then if you scroll down, Ambush, maybe you can like take your cursor over the bladder. You see the bladder's lit up because that's where the FDG is coming out. Where you don't expect it to happen is exactly what Robbie was hypothesizing there in the peritoneum. And I think in the liver as well. It's like there's these areas that are lighting up throughout. So I think this is just like diffuse increase in FDG uptake in areas we don't expect. And I think that is telling you usually when there's increased FDG avidity, it's either infection, it's cancer, it's autoimmune disease. But I think in this case, because we've like done an extensive infectious workup, that becomes less likely. And now the question is, what is the nature of that metabolically active pathology throughout what seems to be the peritoneum? I do have to admit, I can't tell the peritoneum from the GI lumen, et cetera. So I would have to rely on the radiologist to confirm that hypothesis. But it looks like nodules, like where the cursor is, little nodules that are lit up.
Ravi, do you have anything to add?
Oh, how could I? No chance. I unfortunately have to go in a couple of minutes to meet my team for a round. So I will make Proffer as the host and learn from you all.
Okay, so before you go, Ravi, I do want to say this, that you're actually the first person who mentioned cocooning. And basically, this is abdominal cocoon syndrome, which is sclerosing encapsulating peritonitis, which is what Ravi had just mentioned. And you can actually appreciate the cocooning here, how this is not the area which is supposed to light up, as Reza already mentioned. And so this is abnormal uptake around the peritoneum, diffuse uptake. And so this was the first time that we had heard of this condition, abdominal cocoon syndrome. Nobody in the hospital knew what this was, but then we dug deeper into it. And in terms of the causes, as Reza has already mentioned, that we had already ruled out infectious etiologies, so it can be idiopathic. It's a pretty uncommon condition, and it basically mimics bowel obstruction, and this is why the person was not able to eat or drink. And then the PET CT did say that there is suspicion of peritoneal malignancy, possibly secondary to a GI origin, but lacks a definitive primary site. So then the last thing that was left to do was the peritoneal biopsy, and that basically led to the diagnosis of why this abdominal cocooning was happening. And this was basically signet ring cell adenocarcinoma. And interestingly, when we did the gastric biopsy, we couldn't see that, but it was originating from there. But it had metastasized all over the peritoneum and caused the cocooning to the point that we couldn't really appreciate the primary in this case. So basically, this was a case of abdominal cocoon syndrome secondary to signet ring cell adenocarcinoma. And I just want to say, I'm so impressed with how you guys broke it down. From the very start, you guys already like knew where to look, and then towards the end, I was quite impressed because nobody has ever mentioned cocooning and, peritoneal carcinomatosis so like quickly, just with, the information that I gave.
I have to bounce an hour. I'll just jump in to commend you for telling this story in such an engaging way and such a powerful narrative. And ultimately, I think that the mistake that I made was to assume that the ascites explained the nausea and vomiting. And it turns out that really the patient had a gastric origin of his tumor that spread to the peritoneum. And I think it just goes to show you how nuanced and subtle medicine can be. And yeah, I think that I would be really, really curious, given the high rate of signet cell carcinoma in the stomach being very, very deep and requiring a deep gastric biopsy, especially the infiltrative type called Leonidas plastica. I wonder if this patient had a really stiff stomach in some part due to that physiology and also a stiff peritoneum. But ultimately, I think it just goes to show you how in diseases like this, as Prof mentioned, you just got to figure out where you're going to get that biopsy and where you're going to get that piece of tissue. And very, very humbling and very unfortunate diagnosis, a devastating one really for the patient. But thank you so much, Ambish. Prof Rez, I'll shoot you a text in a second. Thank you so much for an awesome hour. And I'll see you guys next time. Safe travels, Ambish.
Yeah, thank you so much, Robbie. Have a good time rounding. Hope you feel better. Very intriguing case. I've never seen, I mean, once you see that image, you'll never forget it, like the cocooning. Very humbling, and ultimately came down to an infiltrative process, as we suspected. So even if you don't, like, cocooning in itself isn't a terminal diagnosis, it's just a consequence of the infiltration with the cancer cells. So I think as long as you know to find yourself in that bucket of diseases, you'll get to an answer. But it's nice to know that there is potentially this finding that is representative of infiltration. And I think it was like, for me, like the main takeaway was just how you can have entrapment of the bowel. Like, I've never heard of this term, but it's very, very good. So thank you so much, Amish. Very interesting case, and like something to add to a lot of our knowledge banks. But if you just, I think, stay in the tenets of clinical reasoning, even if you don't know about cocooning, you'll still get to the diagnosis, because I think on our mind was malignancy, on our mind was infiltration, and it ultimately came down to but it's really a cool way to piece it all together. Thank you for presenting that. Maybe you can share what your main takeaway is, and then we can give the mic to Ethan to wrap up the session.
Thank you, Prof. Rez. That was a very interesting discussion. When I had this case, the first thing that came to my mind was I want to talk to Ravi and Reza about this and see what their thoughts are. And in retrospect, like, what are the things that we missed or, we could have done better? So one thing that I was really intrigued about was, can this be something that can be seen on a CT? And so I went to the radiologist, and my main take home was that in a patient who is as cachectic as this patient, it's hard to appreciate things on a CT, because fat is what basically separates, and helps us identify structures. And so he lacked fat, right? So everything looked very symmetric and edematous, and the only thing we knew was there is compartmentalization, but we couldn't see the encapsulation. Right. So that was one take home for me, that if you have a patient who is severely cachectic, do not rely and just sit around and wait for basic workup. I think it's good to, ramp it up and go towards things like PET CT, and they are very expensive, but I feel like a 3-week stay in the hospital is just as expensive. So that's one take home for me. And the other take home was to suspect, malignancies and kind of again, intensify the workup quickly. And the last thing for me was just very humbling for me. I saw this patient diagnosis. The first step was, you're very frustrated with trying to see what is going on, but that's not always the solution. We knew this is a malignancy. We knew what this was, but we couldn't do anything for him. And that was the worst part. We were all looking for answers, but even when we did have the answer, we just, couldn't do much. So we offered him inpatient chemo, and he was just really adamant on going home and being with his family. So he chose to go home on hospice and be with his family.
Yeah, thank you for sharing that, Ambush. I think the lack of fat is really important when you go to evaluate a radiologic image. And I think even though it's a sad outcome, the fact that you gave him a diagnosis which allowed for a prognosis, it's the first step in accepting a very unfortunate event. So even though it didn't lead to a diagnosis you can cure, it still led to a diagnosis where you can set expectations. And I think expectation setting is so important for us as human beings as to what to expect going forward. So you guys did an incredible job for this patient. Very unfortunate case. Very educational, and hopefully he passed away with his family at his bedside. But let me give the mic to Ethan to take us home. There's so much teaching to be done here, Ethan. Good luck with that.
Oh, what a crazy case. So thank you, Ambish, for the amazing case, and thank you, Reza and Rabi, for the amazing discussion. So we start the case with a 44-year-old male with 2-month history of nausea, vomiting, and weight loss. And nausea is a non-specific symptoms and prompts us to look for more specific symptoms to progress on our differential diagnosis. And when combined with vomiting, it could point to gastrointestinal pathology, but we still have to consider broadly until a pivot point emerges. And then we found out that in Alter Hospital, he was diagnosed presumptively with ascites. And in ascites, we can divide it into two mechanisms. And the first one is the leakage of fluids from vessels due to elevated hydrostatic pressure or decreased oncotic pressure, and with a transudated ascites fluid. And the second is leakage of inflammatory exudate. And the former one usually causes weight gain, and with the patient presenting with volume overload states like cirrhosis or heart failure. And in this patient, he had significant weight loss, which points to a underlying inflammatory nature and suggests the ascites to be exudated, if there is indeed ascites. And in that case, we have to look for SAC to see if there's portal hypertensions, and sampling the fluids to look for neutrophil counts and cultures to see if there is bacterial peritonitis present. And in inflammatory ascites, we could use the IMA mnemonic for helping the differentials. For example, in infections, we could think about TBs and fungal infections. In malignancy, we could think about GI cancers. Or if the patient is a female, we could think about GU cancers as well. And in autoimmune disease, we could think about SLE or Still's disease, etc. And then in this patient, he was given diuretics before, and here's a measurement pearl that we really have to figure out the underlying disease process before giving diuretics, because it is only effective for transudated ascites, but not in exudated ascites. And then we found out on exam that this patient has significant weight loss, which points to the severe underlying disease process. And the relatively normal blood pressure suggests against portal hypertension, which sometimes will present with hypotensions. And the diffusely stiff abdomen would prompt us to think about luminal disease or peritoneal disease, because these are the two organs that present diffusely in the abdomen. And with the subacute disease process, we are thinking about a possibility of subacute peritonitis as part of the underlying syndromes. And in that, there's really not much signature except the elevated alkaline P, and we need to correlate with gamma GT for its origins. And with the normal aminotransfer rates, that could represent an infiltrated disease in the livers. And then we found out in the imaging that there's really isolated diffuse bowel wall thickenings with no extra gastrointestinal signatures. And this presentation is very rare because usually in, for example, like infiltrative disease, there are usually extra gastrointestinal signatures that could prompt us to make the diagnosis, like eosinophilic gastroenteritis, lymphomas, infiltrative disease. But really, in this case, there are no these clues. And we also need to consider nephrotic syndromes or heart failures manifesting the bowel wall edema. But in this case, the albumin is normal and there is really no heart manifestations as well. And then we did a EGD and biopsy, which shows negative findings. So here we need to consider in the deeper structures of the gastrointestinal lumens, the subrotal structures and peritoneal pathologies. And to make progress, we could order MRI or do a exploratory laparotomy and do a biopsies. And finally, we diagnosed the patient with an abdominal cocoon syndrome, which I never heard before. And I Google it, it's known as sclerosing encapsulating peritonitis, and it's a rare condition that causes intentional obstruction by encapsulating the small bowel by a fibrocollagenous membrane. And it is not an end diagnosis, but a result of an inflammatory process causing the formation of the membrane. And this, in this case, is a signet ring adenocarcinoma. Yeah. Thank you very much.
Ethan, if you could just, you're on fire, man. Someone has to get a fire extinguisher and put you out. That was phenomenal, the way you organized the teaching. And I want to just say, like, those last words you used, something I have never heard of, I think is a testament to this community and what we're trying to do, which is improve our knowledge base. And that makes two of us, Ethan. And I'm sure many others who are listening to this, except for Robbie, who knew about it, which is great because it allowed us to learn. So I think that's really one of the important aspects of this community. Ambish, thank you so much for this excellent case. Ethan, phenomenal job with your teaching. Thank you all so much for really getting the day started right on a Friday. Now back to Trendelenburg, right, Khashayar? Take care, everyone. Bye.